Hi, my name is Asim Chowdhury. I'm a pediatric neuroradiologist from Le Bonheur Children's Hospital and the University of Tennessee Health Science Center in Memphis, Tennessee. We're going to be discussing in this series aspects of pediatric neuroradiology related to supratentorial malformations and malformations of cortical development. This is an MRI scan of the brain in a 5-year-old child with seizures. And we start by looking at the T2 weighted image, and we can see an slightly atypical appearance of the ventricular system. The right lateral ventricle is a little bit larger than the left lateral ventricle. But the bigger thing we see is an asymmetry in the sulcation. The normal sulcation pattern we can see here in the frontal poles, where we can see the normal undulation of these gyri. We have the cortical gray matter at the periphery, and this darker area subjacent to that is the white matter. This is a normal sulcation pattern. If we go over here to the right middle frontal gyrus, for instance, we can see very shallow, narrowly spaced gyri. We see a similar appearance over here on the left. And then if I go to the sagittal T1 weighted image, it becomes even more evident that compared to the normal sulcation pattern here in the temporal lobe, we have very shallow, narrowly spaced gyri. And this is what's called polymicrogyria, poly, many, micro, small gyri. We have polymicrogyria here in the inferior frontal gyrus. This is along the sylvian fissure, so this falls under the heading of perisylvian polymicrogyria. But that term is not uniquely descriptive of a given disease pattern, because if we see in this individual, we can see some abnormality in the superior aspect of the superior temporal gyrus. And if we go superiorly, I'm going to go to an axial thin section T1 weighted image. We have polymicrogyria in the bilateral middle frontal gyri. Here's the left middle frontal gyrus, the right middle frontal gyrus, extending posteriorly past the central sulcus, involving the right inferior parietal lobule right here and portions of the right parietal lobe. So this is a case of a bilateral, relatively symmetric polymicrogyria involving the perisylvian white matter as well as additional portions of both parietal and frontal lobes. This is an MRI scan of the brain in a 2-year-old child with developmental delay. And we can already see there is an abnormal sulcation pattern along the insular cortex. I'm going to look at the sagittal images, the sagittal T1 weighted imaging, and we can see shallow, narrowly spaced gyri and subtle blurring of the gray-white differentiation in that location. This is polymicrogyria. This here is the sylvian fissure. We're seeing polymicrogyria along the superior margin of the sylvian fissure in the inferior frontal gyrus and inferior parietal lobule, as well as portions of the superior temporal gyrus. So this is perisylvian polymicrogyria without involvement and a relatively normal sulcation pattern in the frontal lobes otherwise, and the remainder of the temporal lobes. So the predominant involvement is bilaterally in the insular cortex that we see here, as well as the frontal and parietal operculum and the temporal operculum. This is an MRI scan of the brain in a 1-year-old child with seizures and developmental delay. One of the first things that we see is this diffuse bright signal on T2 weighted imaging in the deep juxtacortical and juxtaventricular white matter of both cerebral hemispheres. We see it in the frontal lobes. It's a little bit patchy, slightly asymmetric. We see it in the temporal lobes, occipital lobes, parietal lobes. Within that, we see in the temporal poles, we see a cystic change here on the left and suggestion of a smaller cystic change here on the right. The lateral ventricles are larger than typically expected for this age, and this is likely related to ex vacuo enlargement from decreased volume of the cerebral white matter. So all of these are signs of diffuse bilateral white matter injury and decreased white matter volume. In addition to that white matter injury, we're seeing an abnormal sulcation pattern. We're seeing shallow, narrowly spaced gyri. This is polymicrogyria. Now, it's a little more challenging to see in this case where there's, first of all, myelination in a 1-year-old is not as much as it was in the other cases. Secondly, there's diffuse white matter injury. So that makes seeing the polymicrogyria a little bit more challenging. But if we use all the images we have available to us, we can see here on this sagittal T1 weighted image along the inferior aspect of the inferior frontal gyrus, we can see some narrowly spaced gyri. This is polymicrogyria. Then one additional thing that we see, in addition to the polymicrogyria and diffuse white matter injury, white matter volume loss, and temporal pole cystic changes, is on this susceptibility weighted image, we're seeing areas of susceptibility hypointensity in the periventricular white matter here in the right inferior parietal lobe, and here in the left occipital lobe. These are likely related to dystrophic mineralization. Collectively, these findings are very suggestive of in utero cytomegalovirus infection. One of the other clinical presentations of children with in utero cytomegalovirus infection is congenital sensorineural hearing loss. This is an MRI of the brain in a child with seizures and developmental delay, and we can see a severe paucity of sulcation. The brain surface is relatively featureless. We see a very rudimentary sylvian fissure here on the right, and a shallow version of a similar structure here on the left. So otherwise, it is very featureless. We see a little bit of, in this parasagittal aspect of the frontal lobes, we see the anterior aspect of the cingulate gyrus. If we go here to the sagittal image, we see the parieto-occipital fissure, we see the calcarine sulcus, but otherwise, we're seeing very few sulcations within the cuneus of the occipital lobe, as well as the lingual gyrus of the occipital lobe. If we go a little bit off to the side, we're also seeing minimal sulcation, very featureless brain. In addition to the surface findings of a relatively featureless brain, we're seeing a very thickened, what looks like cortex, but not all of this is really cortex. If we look at an image here, we can see the gray matter at the periphery, but all of this is actually an intervening area. Here in the right occipital lobe, we can see this is the cortex. These little areas where it looks slightly bright is actually white matter. It is what's called the cell sparse zone. Then beneath that is an additional band of gray matter. That band of gray matter follows the surface of the brain throughout both cerebral hemispheres. This deeper gray matter that's in a band-like configuration is not in the normal location, so it's called heterotopic gray matter. This pattern of heterotopic gray matter is called band heterotopia. The smooth surface of the brain is known as lissencephaly. Lissencephaly, especially the more severe forms, is often associated with a band-type heterotopia. Band heterotopia is an abnormality of neuronal migration. We can see other abnormalities here, that there's a severe loss of the cerebral white matter volume. Overall, the brain doesn't have a lot of the landmarks we're used to seeing. The lateral ventricles have a slightly dysmorphic appearance due to the abnormal configuration of the surrounding white matter. And we can see the cerebellum looks closer to normal than the cerebral hemispheres. The cerebellar volume is a little bit lower than usually seen, but compared to the cerebral hemispheres, they're relatively preserved. And this is an abnormality known as lissencephaly with band-type heterotopia. This is an MRI of the brain in a 1-week-old child that had an in utero abnormality that wanted to be further characterized. One of the first things we see is this very, very featureless surface sulcation pattern to the brain. We're seeing a rudimentary sylvian fissure on both sides. At most, it looks sort of like a large figure 8, but we're not seeing any other major sulci. Within that, we're seeing enlargement of both lateral ventricles, more pronounced posteriorly. On the brain, we're actually seeing something that we saw on the other cases. We saw the peripheral cortex. We see a cell sparse zone that's bright on T2 weighted imaging. And then we see what is a band of gray matter-like substance called gray matter heterotopia. So this is a very severe case of lissencephaly with band-type heterotopia. At this point, instead of just lissencephaly, which means smooth brain, it can also be referred to as agyria, because there's essentially no gyri. The coronal image here also shows, you can see the temporal lobe is just one single curve on the periphery with no surface undulations. We see that subtle curvature for this concavity for the sylvian fissure, and we're not seeing any sulcation whatsoever in the frontal lobes. This is a fairly severe appearance. The patient beforehand had a head ultrasound, which also showed a very featureless temporal lobe, very featureless parasagittal cortex here in the frontal lobes. The one thing to be aware of, though, is to be careful on ultrasound especially to not overcall lissencephaly in the setting of severe prematurity. The sulcation pattern that looks abnormal in a term infant could be normal at 32 weeks or 28 weeks. So in a premature infant where some of the brain development has not yet taken place, we have to be careful not to overcall lissencephaly. That said, this severe abnormality is definitely a true lissencephaly. The MRI confirms the self-sparse zone and the band-type heterotopia. So this is a severe case of lissencephaly with band-type heterotopia with an agyric pattern. This is an MRI performed of a woman who is pregnant, and so the MRI is focused on the fetus itself, in particular the brain. There was questions on the ultrasound about the size of the brain and the features of the brain, and so this MRI was performed. And we can see here posteriorly, we can see some sulcation. It's difficult to see in fine detail in a fetal MRI because of the small size, but you can see there's some sulcation in some different substructures. But if we go to the frontal lobes, in particular the frontal poles, this is very featureless. Same with on the left side. So both sides we're not seeing much. If we go to the sagittal view, we're seeing a very featureless frontal lobe. Overall, the brain size is smaller than expected. If you look at the craniofacial ratio, the head does not, and the brain does not project up significantly relative to the size of the face. Here is the nasal bone down to the lower lips and the chin. So we have a smaller than expected brain with a paucity of sulcation anteriorly. The lack of sulcation prior to term infancy is very challenging to assess normal from abnormal. But this infant is, I believe, nearly 30 weeks gestation, at which time you should have more sulcation than this anteriorly. Also, there shouldn't be such an asymmetry between the frontal lobes where we're seeing very little sulcation and posteriorly where we're seeing much more. And this right here is highly suggestive of an anterior predominant lissencephaly spectrum disorder. This was confirmed on postnatal imaging, and it is noted that an anterior predominant lissencephaly oftentimes is related to an abnormality in the DCX gene, DCX. That's in contrast to the posterior predominant lissencephaly, which is related to abnormalities of the LIS1 gene. So this is something that can be done where on the imaging you can at least give some hints at what genetic defects might be causing the structural findings, which can help guide the geneticists, the maternal fetal medicine doctors, the neonatologists, and other and neurologists on what genetic tests to order, because there's so many possible genes out there. But for lissencephaly or relatively featureless parts of the brain, anterior predominant lissencephaly, you think DCX gene. Posterior predominant lissencephaly, you think the LIS1 gene. This is an MRI of the brain in a 2.5-year-old child with developmental delay. On the T2 weighted image, we're seeing the sulcation pattern. We're seeing more gyri than in some of the more recent cases, but it's still not a normal sulcation pattern. We're seeing a paucity of sulcation, and on this sagittal T1 weighted image, we can also see, while we see gyri throughout both cerebral hemispheres, anterior and posterior, it's still not the same degree of sulcation like we normally see. Now, the one thing also that we can see well on the T1 weighted image is we see the nice gray matter, and beneath that we see the white matter. There's no band-type heterotopia. So this is a diffuse mild lissencephaly spectrum disorder involving both cerebral hemispheres, anterior and posteriorly, without band-type heterotopia. This is an MRI of the brain in a newborn, in a child who had an abnormal fetal ultrasound. We can see right away that there's an abnormal configuration of the ventricular system on this T2-weighted image. So there's a monoventricle. There's no two separate lateral ventricles. There's one big, relatively amorphous ventricle. Additionally, we don't have any intrahemispheric fissure. The cortex, which is relatively featureless, of one cerebral hemisphere goes all the way over to the contralateral side. We see likely what is a single anterior cerebral artery. Additionally, we see fusion of both thalami. Now, the cerebral hemispheres are part of the brain called the telencephalon. The thalami are part of the brain called the diencephalon. Those are the parts of the brain in a 5-part mature brain. But developmentally in a 3-part brain, the diencephalon and telencephalon come from what's called the prosencephalon. So an abnormality in the prosencephalon, which we see here with the telencephalic component and the diencephalic component, is a prosencephalic abnormality. This is referred to as holoprosencephaly. Holo meaning one, prosencephalon. So there's one prosencephalon. The two sides of the brain did not split apart from one another. This is a very severe case of holoprosencephaly called alobar holoprosencephaly. Now, the posterior fossa contents can be closer to normal, but the cerebral hemispheres are very abnormal. There's featureless cortex, decreased white matter volume, monoventricle, abnormality of the deep gray nuclei. Additionally, we notice the globes are too close together. The globes, as a rule of thumb, you should be able to put about one globe in between the two of them. This is much less than that. So this is signs of hypotelorism, which is associated with craniofacial abnormalities, and holoprosencephaly is often associated with craniofacial and other midline abnormalities. We can see in this individual here on this sagittal image, here's the pons, here's the medulla oblongata, here's the midbrain. Going forward, we have a very amorphous conglomeration. We do not see discrete mammillary bodies. We do not see a discrete hypothalamus. So all of this is very abnormal. This bright area here is likely a neurohypophyseal area of T1 shortening, but it's not within the cella turcica itself. So it is not uncommon for children with a holoprosencephaly to have other midline defects. Pituitary abnormalities, which goes along with endocrine dysfunction, craniofacial abnormalities, including clefts, as well as bony abnormalities of the spine and other things. So this is a very severe holoprosencephaly spectrum disorder known as alobar holoprosencephaly. This is an ultrasound of the head in a newborn infant that had an abnormal fetal ultrasound. The ultrasound was performed through the anterior fontanelle, and this is in the coronal plane. We can see sulcation here in the location where you'd expect the anterior aspect of the intrahemispheric fissure. You can actually see gray matter and sulcation going across the midline. And so this is not normal. Normally, the two cerebral hemispheres do not have any sulcation that crosses over. At a later age, a CT scan of the head was performed. This shows an abnormal ventricular system. There's no septum pellucidum. The lateral ventricles posteriorly are larger than you would normally expect. And we're not seeing the anterior horns of the lateral ventricles very well. We're not seeing good delineation between the two thalami. And we're also seeing gray matter continuity across the expected location of the intrahemispheric fissure anteriorly. Now, posteriorly, we are seeing a falx cerebri. Anteriorly, we do not see a falx cerebri. So this is an individual that has elements of a holoprosencephaly spectrum disorder, but posteriorly, we look like we have two different cerebral hemispheres, unlike the case of the alobar holoprosencephaly that we saw. But anteriorly, we're seeing signs of a single cerebral hemisphere. An MRI is performed showing some fusion of the thalami, which is a diencephalic structure, and anterior midline continuity across the expected location of the intrahemispheric fissure anteriorly. This corresponds with the appearance on the ultrasound. We also see a single or azygous anterior cerebral artery right here. Posteriorly, we see a falx cerebri, and we see two separate occipital lobes. So this patient has some features of holoprosencephaly, but it's not as severe as the alobar holoprosencephaly that we saw. If we look at this sagittal T1 weighted image, Posteriorly, we see a normal appearing cerebellar vermis, relatively normal appearing brainstem. We can see normal sulcation in the precuneus of the parietal lobe as well as in the occipital lobes here. We're seeing the posterior portion of the corpus callosum, the posterior body, isthmus, and splenium. Anteriorly, we lose the corpus callosum. Anteriorly, we also have, along the intrahemispheric fissure, we have actually gray matter, where there normally should just be white matter. So this is a patient with, posteriorly, it looks like the two cerebral hemispheres separated from one another. Anteriorly, they did not. And this is a holoprosencephaly spectrum disorder, referred to as semi-lobar holoprosencephaly. This is an MRI of the brain in a newborn that had an abnormal fetal ultrasound. And axial T2-weighted image shows a couple of things. First of all, we see this anterior sloping of the frontal bones that goes up to the midline. And midline, well, we don't get a great view of bone on MR compared to CT. It looks like there's actually bone continuity between the two frontal bones, whereas at this young of an age, the metopic suture should be there. So this raises possibility of metopic suture craniosynostosis, which can result in a skull configuration known as trigonocephaly. Now, if we go down further on this coronal image, we can see anteriorly across the intrahemispheric fissure, we have gray matter continuity. We have cortex going all the way across and white matter going across beneath that. That's unrelated to the corpus callosum. So that's not normal. The two cerebral hemispheres should be separate from one another, other than commissural fibers, such as the corpus callosum and anterior commissure. So this gray matter continuity is abnormal. We also have a slightly dysmorphic ventricular system, but much less so than in the case of semi-lobar holoprosencephaly that we saw, and much closer to normal than the case of alobar holoprosencephaly, which we saw. There's some fusion of the thalami, but the thalami are otherwise separately formed. This almost looks like a large massa intermedia. So this patient has a very mild holoprosencephaly spectrum disorder. It is truly speaking a holoprosencephaly spectrum disorder because we have the gray matter of the cortex here, which is a part of the telencephalon, and the thalamic abnormality, which is a part of the diencephalon. But this is a milder end of the spectrum of the holoprosencephaly spectrum disorders, known as lobar holoprosencephaly. We have an intrahemispheric fissure. We still have an azygous anterior cerebral artery here. We have midline continuity. Anteriorly, the falx cerebri is not well developed. Posteriorly, it is developed. So it has some features more normal than the semi-lobar holoprosencephaly, but it has definitely abnormalities that differentiate this from a normal appearing brain from this age. This is an MRI of the brain in a 13-year-old with developmental delay as well as some seizures. And there's several things that we see. First of all, in this image, we do not see a septum pellucidum. If we go up, we actually see there's midline continuity of gray matter across the anterior aspect of the intrahemispheric fissure. Now, if we go down lower, we see two separate thalami. So remember we talked in the holoprosencephaly spectrum disorder that the thalami are a part of the diencephalon, whereas the cerebral hemispheres are a part of the telencephalon. So together, the diencephalon and telencephalon are the prosencephalon. Well, we don't have a prosencephalic abnormality because the diencephalon is normal. So this is an isolated telencephalic abnormality. Well, what else do we see that's abnormal? Well, in this sagittal image, we see segmental dysgenesis of the mid portion of the corpus callosum. There's some gray matter heterotopia here, abnormal gray matter in this location. And if we go to the side, there's almost vertical extension of the sylvian fissures here. And this right here is an abnormality that's known as syntelencephaly, S-Y-N, meaning like synapse, coming together of the telencephalon. It's a milder version even of a holoprosencephaly spectrum disorder. We still see what's an azygous or unpaired anterior cerebral artery and midline continuity of the telencephalon, but we're not seeing all the other features that would make this a true prosencephalic abnormality. So syntelencephaly is an even milder hemispheric cleavage abnormality than lobar holoprosencephaly. This is an MRI of the brain in a 3.5-year-old child with some vision abnormalities. One of the first things we notice is absence of the septum pellucidum. We see the two lateral ventricles are normal in size, but there's no intervening septal leaflets. As we scroll through the brain overall, the sulcation pattern looks normal, the myelination pattern looks appropriate for age. So other than the absence of the septum pellucidum, the brain itself looks fairly normal. If we go to the sagittal T1 weighted image and we zoom in on the suprasellar region, we can see the optic chiasm is smaller than we typically expect. This is the pituitary infundibulum. Here's the adenohypophysis. This area of T1 shortening is the neurohypophysis. Mammillary bodies. Here's the third ventricle. We have the infundibular recess and the chiasmatic recess of the third ventricle. But the optic chiasm is smaller than it typically should be. Well, let's look at the optic nerves otherwise. So on this coronal image, we're going to zoom in, and we can barely see the optic nerves. The bright around it is CSF within the optic nerve sheath, and the optic nerves themselves are small. On this coronal image, we can see the optic nerves are small. We will zoom in, and we can see the optic nerves are small throughout their course in the orbit. Going back here to the optic chiasm, that's the pituitary infundibulum coming down from there. So we can follow the optic nerve bilaterally is small. And the axial image confirms you just see a very thin optic nerve, which is the T2 hypointense structure within the central aspect of the optic nerve sheath. If you remember, the optic nerve is, truly speaking, a part of the central nervous system. It's surrounded by CSF and dura. The dura is the optic nerve sheath. So this patient has bilateral optic nerve hypoplasia, also hypoplasia of the optic chiasm, and absence of the septum pellucidum. That spectrum of abnormalities is known as septo-optic dysplasia. This is an MRI of the brain in an 11-month-old child with small optic nerves that were identified on ophthalmologic examination. On this coronal image, we see absence of the septum pellucidum and otherwise relatively normal appearing lateral ventricles. If we go forward, we see a smaller than expected optic chiasm and smaller than expected optic nerves. So those are the features that we've described with septo-optic dysplasia: absence of the septum pellucidum and hypoplasia of the optic pathway. Now, there's additional features that you can sometimes see. In this patient, we see a focal contour irregularity along the lateral margin of the body of the right lateral ventricle, and that there's this gray matter-lined cleft that goes out to the periphery. And this is a schizencephalic cleft. This is a very subtle schizencephalic cleft. It's nearly what's called a closed lip schizencephaly. Now, a closed lip schizencephaly is where the gray matter margins are up upon one another, and an open lip is where they're widely apart. Now, from my perspective, it's parsing terms to debate whether this is open-lipped or closed-lip schizencephaly, because either way, the parenchymal defect is relatively small, and so we're missing a small amount of brain. So whether you call this a closed-lip schizencephaly or a very narrow open-lip schizencephaly likely has no clinical differentiating features. The issue is that there's not a large gap where there's brain parenchyma missing. So this is a patient with septo-optic dysplasia and a closed lip versus a narrow open lip schizencephalic cleft. This is an MRI of the brain in a 14-year-old with short stature, also with some vision abnormalities. On the axial T2 weighted image, we see the absence of the septum pellucidum. The lateral ventricles otherwise look fairly normal, but there's no intervening septum pellucidum. The brain otherwise looks relatively normal, other than in the anterior aspect of the left middle cranial fossa, we have an arachnoid cyst, which is a normal variant. If we look in this coronal image, we see very small optic nerves in the posterior orbital segment of the optic nerves, with surrounding prominence of the CSF in the optic nerve sheath. Those are signs of optic nerve hypoplasia. If we look at the sagittal T1 weighted image, we see a very small optic chiasm. So a small optic chiasm, small optic nerves, and absence of the septum pellucidum are the features of septo-optic dysplasia. But this individual has one other finding that can be associated with septo-optic dysplasia that we need to be aware of. If we look here, this is the sella turcica, and this here is the adenohypophysis. Normally, posterior to the adenohypophysis, there's a neurohypophyseal area of T1 shortening, or the posterior pituitary bright spot. We don't see a posterior pituitary bright spot. We also don't see a pituitary infundibulum. But what we do see is at the expected location of the infundibular recess of the third ventricle, we see a bright globular area here. This is an ectopic neurohypophysis. The neurohypophysis, which normally migrates down from the hypothalamus down along with the development of the pituitary infundibulum to end up along the posterior aspect of the pituitary gland, never migrated. Interestingly, this is an abnormality that, from an endocrinologic standpoint, usually has little to no posterior pituitary dysfunction. The dysfunction is actually related to the anterior pituitary because, given the lack of migration of the posterior pituitary down to the sella turcica, the pituitary infundibulum doesn't form. And when the pituitary infundibulum doesn't form, the hypothalamic hypophyseal portal venous system does not form. And so therefore, the releasing hormones from the hypothalamus never reach the pituitary gland. So the pituitary gland is understimulated, and therefore you have adenohypophyseal dysfunction, which can manifest with things such as short stature and abnormalities with puberty. This is an MRI of the brain in an 11-month-old child with small optic nerves that were identified on ophthalmologic examination. On this coronal image, we see absence of the septum pellucidum and otherwise relatively normal appearing lateral ventricles. If we go forward, we see a smaller than expected optic chiasm and smaller than expected optic nerves. So those are the features that we've described with septo-optic dysplasia: absence of the septum pellucidum and hypoplasia of the optic pathway. Now, there's additional features that you can sometimes see. In this patient, we see a focal contour irregularity along the lateral margin of the body of the right lateral ventricle, and that there's this gray matter-lined cleft that goes out to the periphery. And this is a schizencephalic cleft. This is a very subtle schizencephalic cleft. It's nearly what's called a closed lip schizencephaly. Now, a closed lip schizencephaly is where the gray matter margins are up upon one another, and an open lip is where they're widely apart. Now, from my perspective, it's parsing terms to debate whether this is open-lipped or closed-lipped schizencephaly, because either way, the parenchymal defect is relatively small, and so we're missing a small amount of brain. So whether you call this a closed-lip schizencephaly or a very narrow open-lip schizencephaly likely has no clinical differentiating features. The issue is that there's not a large gap where there's brain parenchyma missing. So this is a patient with septo-optic dysplasia and a closed lip versus a narrow open lip schizencephalic cleft. This is an MRI scan in an 11-year-old with developmental delay and seizures. As we scroll through, we encounter a number of abnormalities. First, on this sagittal T1 weighted image, we see a thickened splenium and isthmus of the corpus callosum, and we don't see the anterior portions of the corpus callosum. We don't see most of the body, the genu, or the rostrum of the corpus callosum. We see a somewhat thickened anterior commissure. As we scroll up, we see a closed-lip schizencephalic cleft going to the lateral margin of the posterior body of the right lateral ventricle, lined by polymicrogyria. You can see here there are areas of polymicrogyria adjacent to this closed-lip schizencephalic cleft. Here, adjacent to the frontal horns of the lateral ventricles, we're seeing extra areas of gray matter. This is called gray matter heterotopia. In the left cerebral hemisphere, almost corresponding to the same location as this closed-lip schizencephalic cleft, we're seeing something that looks very similar. We're seeing a deep sulcus, but the sulcus doesn't go all the way to the margin of the lateral ventricle. We do see a little trail of gray matter heterotopia. So this is actually what's called a transmantle gray matter heterotopia in the setting of a deep sulcus. So this patient has a transmantle heterotopia with a deep sulcus and some areas of polymicrogyria adjacent to it. On the right side, we have a closed lip schizencephaly lined by polymicrogyria. We have several additional areas of gray matter heterotopia, and we have dysgenesis of the anterior and mid portions of the corpus callosum. This is a young child, approximately 1 year of age, who had enlarged ventricles and bilateral schizencephalic clefts. A shunt was placed, so you can see this ventriculostomy catheter that goes into this large CSF space. And we can see a large left-sided open lip schizencephalic cleft, or what looks like that. We can confirm that on MRI when we confirm that it's lined by gray matter. And also a right-sided schizencephalic cleft. Once the shunt was placed, we can see the CSF space decreased in size. There's been decreased mass effect upon the remaining parenchyma of the left frontal lobe and the left occipital lobe. Here is the MRI appearance of the shunt apparatus. And notice that the right-sided schizencephalic cleft, you barely can see CSF going through it. So this now is closer to what people would refer to as a closed lip schizencephaly. You can see in this patient, there's abnormal sulcation lining the margins of the schizencephalic cleft. So it's gray matter with polymicrogyria. If we go to the right side, we also see areas of polymicrogyria. That shows up better on this axial T1 weighted image, where you have polymicrogyria lining this cleft. Now, this also brings about the challenges in pediatric imaging, where due to their small size and due to some movement, even sometimes if they're getting sedated, it can be difficult to get pristine images like you see in a textbook on every single case. But you don't need it. You don't need to prolong sedation in a child to get an image for a textbook, as long as you can make a diagnosis. So if you know what you're looking for, if you make your diagnosis, all you need is images that can help you make your diagnosis. And so this patient has bilateral schizencephaly, a large open lip left-sided schizencephalic cleft, and a very narrow open lip versus closed lip right-sided schizencephalic cleft. This is an MRI in a 3-year-old child with seizures and developmental delay. We can see a lot of aspects of the cerebral hemispheres look normal. But as we go inferiorly, in the posterior aspect of the right temporal lobe and the right occipital lobe, we see a very abnormal appearance of the cortex. We don't see a normal sulcation pattern, and we also don't see normal white matter. At this age, the white matter should be relatively hypointense on T2 weighted imaging, as we see here on the left, but we're not seeing that on the right. On sagittal T1 weighted imaging, we're seeing a very irregular sulcation pattern, some areas of polymicrogyria, but that doesn't tell the whole picture. If we go to a thin section axial T1 weighted image, we see small areas of gray matter heterotopia within the deep white matter. We see gray matter heterotopia along the margins of the lateral ventricle, which is subependymal heterotopia. This here, where it's heterotopia that's not within the subependymal region, but in the white matter, is called subcortical heterotopia. So this patient has multifocal areas of subependymal and subcortical heterotopia, some overlying polymicrogyria involving, as we can see here, is the posterior aspect of the lateral surface of the right temporal lobe, extending posteriorly to the right occipital lobe. This is an MRI of the brain in a 9.5-year-old child with headaches. And at first glance, everything looks normal. In a normal MRI, I look for the size and symmetry of the lateral ventricles. The lateral ventricles look normal size and appropriate morphology and symmetry. Third ventricle, fourth ventricle. At this age, we're seeing near complete to complete myelination, where on T2 weighted imaging, everything looks hypointense for the myelinated white matter. By 9.5 years old, the only white matter which is unmyelinated is very subtle peripheral juxtacortical connections in the frontal lobes, which is typically below the ability to detect on MR imaging. So everything looks fairly normal. It's important when looking at MRI to look at all imaging sequences, one of which is the diffusion weighted image. And people are used to using diffusion weighted imaging to look for strokes. And diffusion weighted imaging is excellent for looking at strokes, excellent for looking for abscess, empyema, things like that. But there's more information provided. We can already see in here, there's a different appearance between the gray matter at the periphery and the white matter. The gray matter looks a little bit brighter, and that's normal. That's expected. Well, we can use that to our favor as we're looking through here. We see a little focus of gray matter right here along the superlateral margin of the body of the left lateral ventricle. If I look at this T2-weighted image, I see a very subtle nodular area of gray matter. If I go back to this sagittal T1-weighted image, I can see a small focus of gray matter, and on the coronal stir, here is the right caudate body, here's the left caudate body. Just superior to that is a small focus of gray matter. So while it otherwise looks like a normal study, the diffusion-weighted image, which normally we don't think about using for things other than stroke or abscess, actually was able to alert us to a very small focus of gray matter heterotopia. This is an MRI of the brain in a child with developmental delay. And if we look on the T2-weighted imaging, we're seeing ill-defined gray-white differentiation posteriorly in the occipital lobes. If I go to the sagittal T1-weighted image, I actually get a little better delineation. I see the cortex at the periphery. Intervening is an area of white matter. The myelinated white matter looks bright on T1-weighted imaging. And then following that, beneath the surface, I'm seeing an additional area of gray matter-like signal. This is band-type heterotopia in the absence of a significant lissencephaly spectrum disorder. The band heterotopia is seen most pronounced posteriorly in this individual. Anteriorly, here in the frontal lobes, we're seeing gray matter and subjacent white matter without band heterotopia. We're not seeing any significant lissencephaly appearance, so this is band heterotopia in the absence of lissencephaly. If we look at this coronal stir image, you can see it a little bit better than the original T2-weighted image. And then one trick you can do is you can actually, on a stir or a T2-weighted image, you can invert from a gray-white perspective. And that sometimes makes it almost look similar to a T1-weighted image. And you can see this band of gray matter going beneath the cortical surface. It's a little more evident than it was without the inversion. This is an MRI scan of the brain in a 5-year-old child with developmental delay. One of the first things we see is there's an abnormal configuration of the lateral ventricles. The body of the lateral ventricles are somewhat parallel, whereas normally they sort of angle laterally as you go posteriorly. So there's a parallel body of both lateral ventricles. As we go inferiorly, the atria and occipital horns of both lateral ventricles are larger than we typically see. This is called colpocephaly. As we go up, we're seeing no intervening corpus callosum. If we go to the sagittal T1-weighted image, for the midline structures, we do not see any aspect of the corpus callosum. Additionally, normally just above the corpus callosum is the cingulate gyrus, which runs anterior and posteriorly. Here, we do not see that. We see these radiating gyri that come all the way down to the third ventricle here. We also see here's the anterior commissure, which is a little on the small side, but otherwise we're not seeing any commissural fibers of the corpus callosum. If we look on a coronal image, we can see a vertically oriented third ventricle, and there's no intervening corpus callosum. If we go back to this sagittal T1-weighted image, the distal branches of the anterior cerebral artery have a very low position. Normally they would go superior to the corpus callosum and extend as the pericallosal artery. Those have a very low position that we can see right here, nearly as low as the level of the internal cerebral veins. One of the other things we see, in addition to this vertically oriented third ventricle, there's a characteristic configuration of the interface between the third ventricle and the lateral ventricles, which has sometimes been referred to as a Texas Longhorn sign, or in some cases like this, may look sort of like Bullwinkle the moose. Along the medial margin of the body of those lateral ventricles, there's a bundle of white matter here. These are the fibers that would have crossed the corpus callosum, but they don't. So they are directed anterior-posteriorly instead of directed laterally to go across the corpus callosum. This area is known as Probst bundles. One other thing we see in this child is there's an increased axial length of both globes. If we look from the anterior aspect of the cornea to the level of the optic nerve insertion, there's sort of some posterior protrusion and an increased axial length. This needs to be further characterized with an ophthalmologic examination and may be indicative of some underlying genetic underpinnings to this disease process. This is an MRI of the brain in a 9-month-old child with developmental delay. And on this sagittal image, there's a few things that we can notice. First of all, we do not see any corpus callosum. But secondly, unlike the prior case of agenesis of the corpus callosum, we're seeing a very high positioning of the superior aspect of the third ventricle. We're seeing cerebrospinal fluid all the way up in the intrahemispheric fissure, which normally you don't see. If we look at this on the axial image, we can see there's a cystic structure associated with the superior aspect of the third ventricle. It's actually displacing some of the vessels here, the distal branches of the anterior cerebral artery, and we can go all the way to the top. We do not see an intervening corpus callosum. Similar to the other case of agenesis of the corpus callosum, we have a parallel configuration of the body of both lateral ventricles. We have enlargement of the atria and occipital horns of both lateral ventricles, known as colpocephaly. On a coronal image, we see the vertically oriented third ventricle with direct continuity with the intrahemispheric fissure. We see an atypical configuration between the third ventricle and the lateral ventricles, sometimes referred to as the Texas Longhorn sign. We see here, on this case, because the patient is young and the white matter is not fully myelinated, we actually, along the medial margin of the body of the parallel lateral ventricles, see an area of dark white matter. This here is very subtle early myelination, resulting in a T2 hypointense appearance within the Probst bundles. The Probst bundles are anterior-posteriorly directed fibers that are the fibers that would have crossed and become commissural fibers crossing the corpus callosum, but they stay here in this location. So these are the Probst bundles. This is a vertically oriented third ventricle with an intrahemispheric cyst. Agenesis of the corpus callosum is often associated with an intrahemispheric cyst. It's unclear if it's truly an arachnoid cyst, or some people have referred to this as cystic meningeal dysplasia related to the abnormal development. Either way, it forms as a cyst and occasionally can enlarge and may require shunting or fenestration. This is an MRI of a 6-year-old child with developmental delay. One of the first things we see on this mid-sagittal T1 weighted image is there's a dysplastic appearance of the corpus callosum. The corpus callosum is foreshortened in the AP dimension. We see the splenium of the corpus callosum, the isthmus, the body, the genu, and the rostrum. We see what looks like all the parts of it, but it's just smaller than we normally expect. The splenium of the corpus callosum should normally go posteriorly to be posterior and superior to the pineal gland right here. The anterior commissure is also small in caliber. If we look on the axial T2 weighted image, we see an irregular configuration of the lateral ventricles. Additionally, on the lateral margin of the body of the left lateral ventricle, we're seeing some areas of irregular gray matter. So this is gray matter heterotopia. So this is a patient that has dysgenesis of the corpus callosum with gray matter heterotopia and an abnormal configuration of the ventricular system. Now, this patient also had seizures, and one of the treatments for seizures, in particular seizures with drop attacks where a patient may fall, is transection of the corpus callosum. So 2 years later, this is a mid-sagittal T1 weighted image after there was surgical transection of the corpus callosum. You can see on the axial image, this is in the early postoperative period, and we can see they've transected the fibers that were once crossing the midline in the corpus callosum. What this allows in a patient with what's called a drop attack, or when they have a seizure, they fall over, this prevents propagation of the seizure to the contralateral cerebral hemisphere, in which case the patient, when they have the episode, they do not lose full control of their body. Half of their body maintains control, so instead of falling over, they still have the ability to maintain some balance and catch themselves. One of the things postoperatively we may do is look at DTI imaging. In particular, this is the directionally encoded fractional anisotropy map. Red is the color of transversely oriented fibers, and we can see there's transection of the transversely oriented fibers in what was previously was the rudimentary corpus callosum in this individual. We can also process that as diffusion tensor fiber tracking, and we can see these fibers go up to the transected margin of the corpus callosum, but they don't cross over. Similar if we do a seed in the contralateral cerebral hemisphere, and we can check different white matter bundles in different portions of the brain, and here we do not see any fibers crossing the corpus callosum. These images with the diffusion tensor fiber tracking are one way to show the epilepsy neurologist and the neurosurgeon postoperatively that there has been complete transection of the commissural fibers traversing the midline in the corpus callosum. This is an MRI of a child who's 5.5 years old with developmental delay. And if we look at the mid-sagittal T1 weighted imaging, we're not seeing what looks like a normal corpus callosum, similar to the patients with the agenesis of the corpus callosum, which we saw before. We have a parallel appearance of the body of the lateral ventricles, and we have mild enlargement of the atria and occipital horns of both lateral ventricles, left greater than right, sort of a milder version of colpocephaly than in some of the other cases that we've seen. Now, this is not a true agenesis of the corpus callosum, because if we look here, we actually see some midline commissural fibers in a portion of the corpus callosum. If we go back to the mid-sagittal image, we see a very, very small area. So this is not complete agenesis of the corpus callosum, which means complete absence, but this is definitely a very severe dysgenesis or abnormal development of the corpus callosum. In terms of other commissural fibers, we see a small anterior commissure right here. Otherwise, all the other features of agenesis of the corpus callosum seem present. We're seeing a low position of the distal branches of the anterior cerebral artery, which would have been the pericallosal artery. We're seeing absence of a cingulate gyrus. We're seeing these radiating gyri. So normally the parasagittal gyri of a cerebral hemisphere stops at the level of the cingulate gyrus, which goes anterior posteriorly, whereas here we're not seeing it, and so we have these gyri that radiate all the way out. The corpus callosum would normally be here with the cingulate gyrus above it. Given that that's absent, this area here becomes relevant because we have these gyri that radiate all the way out from the third ventricle. Whereas if there was a cingulate gyrus present, that would not be present. On the coronal image, we also see a vertically oriented third ventricle and a lot of things that look, the configuration looks somewhat similar to the agenesis of the corpus callosum cases, but we actually do see a portion of the corpus callosum in the midline. This dark area here on this STIR image are myelinated fibers in the remaining portion of the corpus callosum. So this is a patient with severe dysgenesis of the corpus callosum, but not complete agenesis. This is an MRI scan in a 7-year-old child with headache, and at the level of the body of the lateral ventricles, there's normal symmetry between both cerebral hemispheres, and everything looks okay. If we go inferiorly, we see this prominent area of bright signal on T2 weighted imaging. If I go anteriorly on the coronal STIR, we also see the anterior aspect of the left middle cranial fossa is filled with fluid and is also actually, if we look at the transverse dimension of the anterior aspect of the left middle cranial fossa, it's slightly larger than the anterior aspect of the right middle cranial fossa. Enlargement of an area is typically a sign of a chronic process. If we look at FLAIR imaging, we can see that the area that was bright on T2 weighted imaging is dark. This confirms that we have pure fluid signal. On T1 weighted imaging, we can see the posterior margin of this fluid collection, there's brain parenchyma with gray matter. This is important because if there was a prior stroke involving the anterior aspect of the left temporal lobe, then we would not have a margin of gray matter at the interface. The gray matter would have been injured and you would go straight to white matter. So this is a sign that this is not an acquired injury to the brain. Diffusion weighted imaging shows that this area has no restricted diffusion. At this point, we can be fairly confident that this finding in the anterior aspect of the left middle cranial fossa is an arachnoid cyst. It is bright on T2 weighted imaging. It shows suppression on FLAIR imaging. It shows absence of diffusion restriction. And we do not see any signs of injury to the subjacent brain. In contrast, if we saw bright signal on diffusion weighted imaging, that would be suggestive of this being an epidermoid. Diffusion is always important to look at on a suspected arachnoid cyst because an epidermoid cyst can look like an arachnoid cyst on regular imaging. It can be bright on T2 weighted imaging, and it can actually suppress on FLAIR imaging. While there is no signs of injury to the left temporal lobe, the space-occupying aspect of this arachnoid cyst does result in slight hypoplasia of the left temporal pole. It also results in slight bony expansion of the anterior aspect of the cranial fossa. We can see on the right a normal greater sphenoid wing. We can see the contour along the anterior aspect of the middle cranial fossa. On the left side, this is bowed anteriorly. In contrast to the margins of the right greater sphenoid wing, the left looks smaller. That's because there's been bony remodeling from chronic pressure from this arachnoid cyst. This is chronic low pressure, not high pressure. This is important to notice because these findings, if they can confirm an arachnoid cyst, indicate this is an incidental finding. Arachnoid cysts very rarely cause symptoms and very rarely require intervention. This is an MRI scan of the brain in a 2.5-month-old child with severe seizures, predominantly infecting the right side of the body. Immediately, we see several abnormalities. First of all, we see an asymmetry in the size of the left hemicranium. We can see here the left hemicranium is larger than the right. The left cerebral hemisphere looks larger than the right. The left lateral ventricle, especially posteriorly, looks larger than the right. Anytime you have a hemispheric asymmetry, the first thing to figure out is whether one side is too big or one side is too small. In most cases, the side that is too small is the abnormal hemisphere. But there's one case where the side that is larger is the abnormal side, and that's this case. This is called hemimegalencephaly. Hemi meaning half, mega meaning big, and cephaly meaning head or brain. So half of the brain is too big. And we can see several different abnormalities. First of all, posteriorly, we see thickened cortex, which is a featureless surface. So this is a lissencephaly-like appearance. We're seeing white matter signal abnormalities subjacent to that. We're seeing ipsilateral enlargement of the right lateral ventricle. Now, I mentioned in hemispheric size asymmetry, trying to figure out which side is abnormal. In general, a rule of thumb is the side with the larger ventricle is the abnormal side. So here, even though the left side is abnormal, it also has a bigger ventricle. Now, anteriorly, the brain is not normal either. We have areas where we don't see the sulcation as well, and this is actually a focal area of polymicrogyria in the left middle frontal gyrus. And then if we look at the white matter in the left cerebral hemisphere is darker than the white matter in the right cerebral hemisphere. In hemimegalencephaly, it is not uncommon to have accelerated myelination. Some of these features can be seen on T1 weighted imaging, where you have a subtle, hazy, intermediate bright signal in the white matter compared to the normally expected hypomyelination at this age seen in the right cerebral hemisphere. So this is likely a sign of accelerated myelination in the abnormal hemisphere in the setting of hemimegalencephaly. One of the things that can be done to treat hemimegalencephaly, given that it is often refractory to medical therapy, is a procedure called a functional hemispherectomy. A functional hemispherectomy has to do with either resection or disconnection of nearly the entirety of the left cerebral hemisphere. We see here on this early postoperative image, there has been resection of the left temporal lobe. There has been resection of the left insular cortex. But the frontal pole and the occipital pole remains present. Instead of removing it, they disconnect. So we see this transection go from the margin of the temporal lobectomy to the posterior aspect of the intrahemispheric fissure. So this posterior cortex remains, but even if a seizure arose from this area, it will not propagate to the rest of the brain because it has been completely disconnected. Similar, the frontal lobe has been disconnected. There's some parenchyma near the vertex also in the left cerebral hemisphere, the posterior frontal lobe as well as the parietal lobe that is present. The way this is disconnected is they do a corpus callosotomy at the time of the procedure. So here we see a transection going in towards the interhemispheric fissure, and we see the corpus callosum has been transected. So the remaining portions of the left frontal lobe and left occipital lobe, as well as up near the vertex, the left parietal lobe, while they remain present, they do not have the ability to have seizures propagate to the right cerebral hemisphere or the working cerebral hemisphere. There's a few things to be aware of in this. First of all, this procedure of a functional hemispherectomy works well and works best in very young children, often performed by the first year of life. Why is that? Because normally the right cerebral hemisphere controls the left side of the body for motor and sensory, and the left cerebral hemisphere controls the right side of the body. If a functional hemispherectomy takes place prior to full maturation of the brain, it is possible for the right cerebral hemisphere to also retain the ability to control the right side of the body. So therefore, a patient with a functional hemispherectomy will not be hemiparetic. The other issue is language. In a majority of individuals, the left cerebral hemisphere is where language is centered. In this individual where there was left-sided hemimegalencephaly, there was a chance, if the functional hemispherectomy was performed later after development of language, that the patient would have severe impairment. But performing some of these surgeries prior to full maturation of motor and language functions gives the chance for the remaining cerebral hemisphere to take over some of those functions. This is an MRI in a 10-year-old child with headache, and we see an abnormality. We see an area of bright signal in the posterior aspect of the interhemispheric fissure. And on the sagittal T1 weighted image, we see along the superior aspect of the corpus callosum an area that is bright with adjacent hypointense signal. This sagittal T1 weighted image is performed with a gradient technique. One of the things you can do is actually use a regular spin echo technique, and some of this susceptibility artifact along the edge goes away, and you can see this curvilinear area of T1 shortening, bright signal, that goes along the superior margin of the corpus callosum. You can see the normal portions of the corpus callosum. There's the rostrum, the genu, the body, the isthmus, and the splenium of the corpus callosum. The lipoma follows all the way from the anterior body over the isthmus and splenium and hooks around the splenium. This is likely a lipoma of the corpus callosum, but to confirm what it is, we use fat-suppressed imaging, where we keep all other parameters identical, and we see that this bright signal on T1 weighted imaging goes away. This confirms that it's a lipoma, that it's just fat. An intracranial lipoma is often in the midline. Along the superior margin of the corpus callosum is one of the most common places. It's considered to be an incidental finding. One thing to be aware of, as we saw on that gradient T1 weighted image and also on the susceptibility weighted image, you often see susceptibility hypointensity along the margins of the callosal lipoma. That can be totally normal, and that should not dissuade you from this being the diagnosis. This is an MRI of the brain in a 3-year-old child with developmental delay, and there's nice normal appearance of the lateral ventricles, appropriate myelination in both cerebral hemispheres. We're not seeing any issues yet until we get down a little bit lower. On the right posterior aspect of the mesencephalon, we see this area of T1 shortening. We don't know for certain what this is yet, but there's a couple things we can do. One of the things people will sometimes do to evaluate a finding is do post-contrast imaging. It's still bright on post-contrast imaging, but on post-contrast imaging, we don't know if this is bright signal from post-contrast enhancement or if it's the intrinsic T1 shortening from this finding to begin with. However, prior to giving contrast, T1 fat-suppressed imaging was performed, and the bright signal went away. That confirms that this is fat, and so therefore it is a lipoma. And similarly, on post-contrast imaging, the post-contrast bright signal that we see here on this post-contrast T1 weighted imaging goes away on post-contrast T1 weighted imaging with fat suppression. So therefore, this finding has bright signal related to fat, which is a small lipoma of the tectal plate, and is not an enhancing lesion. If it did not suppress on fat-suppressed imaging, then you have to wonder about other possible sources of intrinsic T1 shortening. One of the most common ones is subacute blood products, or methemoglobin. In this patient, that small area of bright signal on T1 weighted imaging was originally raised as concern for a hematoma, but appropriate use of fat-suppressed imaging helped confirm that it was not a hematoma. A tectal plate lipoma will often show up at either the 5 o'clock or the 7 o'clock position, and that's exactly where we see it in this individual. So being aware of the normal location for this lipoma, as well as being aware of the MRI techniques you can use to confirm the fatty nature, fat-suppressed imaging, both pre and post-contrast in this case, it allows you to confidently state that this is an incidental lipoma that does not require follow-up and should have no implications to the brain development.
Hello, my name is Asim Chowdhury. I'm a pediatric neuroradiologist at LeBonner Children's Hospital in Memphis, Tennessee. Previously, we discussed supratentorial malformations of the pediatric brain. Now I want to discuss the companion topic, posterior fossa malformations or infratentorial malformations. These can be confusing, but we encounter them regularly in both clinical practice and in testing situations. And so my goal is to help make this topic less confusing. This is a fetal ultrasound performed at approximately 22 weeks of gestation. We can see here's the thoracic spine, the lumbar spine going down to the sacrum. And posteriorly, we see this bubble-like projection that extends posteriorly and has predominantly fluid-like signal within it. That is suspicious for a lumbosacral myelomeningocele. Fetal MRI shows this cystic-like projection, and it is not skin covered. We're not seeing skin going over it, but we do see neural elements entering it. This is actually the caudal aspect of the spinal cord. So leading to what's called the neural placode. This is a cause of a continuous cerebrospinal fluid leak that results in abnormally low pressures in the central nervous system of the CSF during development. And we can see that results in the cerebellum taking a configuration where it wraps around the brainstem. This is the MRI correlate on this fetal MRI of something referred to on fetal ultrasound as a banana sign, where this cerebellum looks like a banana wrapped around the brainstem. This is an MRI of the brain performed in a 1-day-old child that had a known posterior fossa developmental abnormality in utero. The head is on its side right now due to this abnormality. So if we zoom out, we can see there is this occipital encephalocele, and we have protrusion of brain parenchyma into this encephalocele, and we have cystic membranes in there and a large CSF collection posteriorly. I'm going to rotate this to a more standard anatomic orientation, and I'm going to show this sagittal image, which shows we see the occipital lobes protruding into this through this defect and the cerebellum. In addition to that, we see actually a large massa intermedia. There's actually sort of posterior displacement of the tectal plate. And additionally, we have syringohydromyelia in the lower cervical cord. So these are features of an occipital and cerebellar encephalocele with intracranial developmental abnormalities, which form a constellation of features that can be referred to as a Chiari type 3 malformation. A Chiari type 2 malformation is intracranial developmental abnormality that is secondary to a myelomeningocele in the spine, typically lumbosacral. And because of that, you get a constant CSF leak that results in low intracranial pressures and resultant sagging of the brainstem and cerebellum into the foramen magnum. That sagging takes place during development, so you get an enlarged foramen magnum. In this case, we have some of the same features of a defect, but instead of it being a spinal defect, it's a defect in the posterior cranial fossa here. So a encephalocele that results in some of the features that you sometimes see in a Chiari type 2 malformation is something that can result in a clinical phenotype referred to as a Chiari type 3 malformation. Now, a Chiari type 3 malformation is a characterization of what's going on, but it is not uniquely descriptive of each patient. In each patient, you have to decide what is involved, what is normal, what is abnormal, and you have to determine how big is the abnormality. So we measure the craniocaudal extent and the transverse extent of the defect. We have to determine whether major blood vessels go in there. In this case, we have the internal cerebral veins and the straight sinus that's protruding back into this. So I believe the torcula is going to be within this herniated, protruding area of brain. Well, that's important because a neurosurgeon can't just say, well, this is a atretic brain, I'm going to transect it at the defect. They need to find out what is protruding into there. They also benefit from us being able to determine what membranes exist, whether some of these membranes need shunting, need marsupialization, or other treatment. So this is an occipital encephalocele resulting in, among other things, features of a Chiari type 3 phenotype. This is an MRI of the brain in a 6-year-old female that was performed for abnormal gait. And supratentorially, we can see the lateral ventricles are slightly larger than usually seen. The third ventricle is also upper normal in caliber. But the rest of the brain parenchyma looks fairly normal. But if we go to the posterior fossa, there's an abnormality that at first can be difficult to identify, because anytime you have either a bilateral symmetric abnormality or an abnormality in the midline, it can be very challenging to identify. And I think it's actually easier to see this sometimes on a coronal view, where we see there's midline continuity between the cerebellar hemispheres. There normally should be an intervening cerebellar vermis. Now, if we look closely at this axial T2 image, we do see a small rudimentary cerebellar vermis. So it's not completely absent. But for the most part, we have midline continuity between the two cerebellar hemispheres, likely midline continuity or at least close apposition of the dentate nuclei in the deep cerebellar gray matter. So this is an entity called rhombencephalosynapsis. During development, the rhombencephalon is the hindbrain. And if we think synapse is comes together, so rhombencephalosynapsis means the rhombencephalon has come together. Or in this case, actually, it never cleaved, it stayed together. So if we look on this sagittal view, we see the cerebellar vermis, or what should be the vermis, doesn't have a normal foliation pattern for a vermis. This actually looks like a cerebellar foliation pattern with the branching points and secondary branching points here. We're not seeing the normal primary and secondary fissures of the cerebellum. We're seeing something that looks more like a cerebellar hemisphere than a cerebellar vermis. Now, anteriorly and inferiorly, we do see this, which is the rudimentary cerebellar vermis. So it's a little bit trickier to identify on this sagittal image, but on the coronal image, we can see midline continuity of the fovea across both cerebellar hemispheres. And additionally, we see that in the axial T2-weighted image, where we have both the gray matter, white matter, and deep gray structures that come together. So this is a case of rhombencephalosynapsis. This is a fetal ultrasound performed at 29 weeks gestation, and it shows profound ventriculomegaly. We can actually see dangling choroid plexus, and this was further characterized with fetal MR. That fetal MR shows massive enlargement of both lateral ventricles. If we scroll inferiorly, the third ventricle is on the bigger side. The fourth ventricle is not enlarged. If we look at this sagittal image, we see the massive enlargement of the lateral ventricles. There's enlargement of the third ventricle. And if I zoom in, I can actually see the superior aspect of the aqueduct of Sylvius looks patent. We're not seeing it inferiorly. And while this is a very small structure, the fact that we have a triventricular ventriculomegaly, both lateral ventricles and the third ventricle, without an abnormality of the fourth ventricle, or at least without enlargement of the fourth ventricle, suggests that the aqueduct of Sylvius is a likely location for an abnormality of CSF flow. Now, there's another finding that we see. The cerebellar vermis has an unusual configuration, including an abnormal configuration of the non-dilated fourth ventricle. If we look on this image, we're actually an axial image of the posterior fossa. We're not seeing a cerebellar vermis, and we're seeing sort of a rounded appearance of the posterior aspect of the cerebellum. That, to me, is suggestive of rhombencephalosynapsis. Obviously, we want to confirm this with postnatal imaging, but this is suggestive of rhombencephalosynapsis. And why does this make sense? Well, rhombencephalosynapsis can be associated with a congenital aqueductal stenosis. That congenital aqueductal stenosis is felt to be related to abnormal transverse migration of the inferior colliculi, resulting in something that could be referred to as mesencephalosynapsis. So in patients with aqueductal stenosis, always pay attention to the cerebellar vermis, and you may actually find that there's also associated rhombencephalosynapsis. That may then allow appropriate referral to genetics for evaluation of other genetic abnormalities. This is an MRI of the brain in a 1-week-old child that had an abnormal fetal MRI and fetal ultrasound. We can see massive enlargement of both lateral ventricles and the third ventricle. But if we go inferiorly, the fourth ventricle is non-dilated. And further confirming our suspicion on the fetal MRI, we do not see a cerebellar vermis. We see midline continuity of the cerebellar hemispheres. Sagittal image again shows massive enlargement of the lateral ventricles, enlargement of the third ventricle, distension of the superior aspect of the aqueduct of Sylvius, but tapering. The aqueduct of Sylvius tapers, and we do not see any patency of that caudal to this point. This is, therefore, a congenital aqueductal stenosis with triventricular hydrocephalus. By triventricular, I mean the two lateral ventricles and the third ventricle, and the fourth ventricle is not dilated. Now, while the fourth ventricle is not dilated, it's not normal. It has an abnormal configuration. Now, that abnormal configuration is partially because these massively enlarged ventricles are distorting everything in the posterior cranial fossa. But if we look on this axial image, we can see the cerebellum in the fourth ventricle probably did not develop normally. But it's very difficult to tell for several reasons. To fully characterize it, it's helpful if the child is older, the brain is larger. And right now, the massively enlarged lateral ventricles are impairing our ability to understand the normal configuration of the posterior cranial fossa. Well, approximately a year later, an MRI was performed, we can see a ventriculostomy catheter in place. The ventricles have come down markedly in size. And now we can see there is no cerebellar vermis. The posterior margin of the cerebellar hemispheres forms this contiguous arc right here, continuity between the two cerebellar hemispheres. So this is a case of rhombencephalosynapsis with additionally congenital aqueductal stenosis, possibly related to incomplete transverse migration of the intercolliculi, also referred to sometimes as mesencephalosynapsis. This is an MRI of the brain in a 2-year-old child with developmental delay. So as we're looking, the cerebral hemispheres look fairly normal. We have good myelination that is appropriate for a 2-year-old child. The ventricular system is normal. We're not seeing any asymmetry. We're not seeing any other suspicious lesions. Now, if we get to the posterior fossa, there's something that stands out, and it can be tricky to catch if you're not paying attention because it's a midline finding, and it's in particular the absence of something. And I'm not seeing a cerebellar vermis right here. I'm seeing the right cerebellar hemisphere. I'm seeing the left cerebellar hemisphere. And in between, I'm not really seeing a cerebellar vermis. Now, if I go superiorly, maybe I see a small vermis. If I look on this sagittal image, all this is the cerebellum, cerebellar hemispheres. This is the small cerebellar vermis. We can see the fourth ventricle. So there's a hypoplastic cerebellar vermis, but there's no cystic dilation of the posterior fossa. So it's a hypoplastic cerebellar vermis that could easily be overlooked. But what else do we see? If we look, the superior cerebellar peduncles are parallel bilaterally. They're parallel. And additionally, in this appearance, they're thickened right here. And this appearance here has been likened to that of a molar tooth, where here is the visible portion of the tooth, and these are the roots, the thickened roots that come down and end up being somewhat parallel. So the classic molar tooth abnormality is an entity called Joubert syndrome, where there is a molar tooth abnormality in the setting of a hypoplastic cerebellar vermis. The molar tooth abnormality in the parallel thickened superior cerebellar peduncles is related to incomplete decussation of the fibers of the superior cerebellar peduncle in the midbrain. Now, some diffusion tensor fiber tracking studies have shown that these patients sometimes also may not have a pyramidal decussation. So what that means is their right side of the brain could be predominantly involved in motor for the right side of the body, which is different than the typical configuration. So this is a patient with a Vermian hypoplasia, a molar tooth abnormality, and collectively this is known as Joubert syndrome. This is a CAT scan of the head in a 17-year-old with altered mental status. And we're not seeing anything concerning for any acute abnormality. But we do see a lesion in the region of the right ambient cistern that has an area of low density and an area of high density. If I zoom in, the area of low density has a density of approximately negative 81 Hounsfield units. So this is consistent with fat. But there's also a very high density structure next to it. And that's where this bone algorithm coronal image from the CAT scan helps. We can see an ossified structure right next to it. So we have fat and we have abnormal ossification. And MRI is an excellent way to further characterize. On this MRI, we see this structure in the region of the right ambient cistern, and it is hyperintense on T1 weighted imaging. demonstrates T1 shortening. The brainstem adjacent to it looks normal. The rest of the brain looks normal. Well, what's one of the ways we use to characterize something? We can give contrast. But the problem is that how do we tell what's enhancing if something was bright to begin with on T1 weighted imaging? We use bright signal on post-contrast T1 weighted imaging to look for locations of gadolinium. But if something's bright to begin with, it may be very difficult to tell superimposed abnormality. Well, that's where fat suppressed imaging comes in. This is a T1 post-contrast fat suppressed image, and we're not seeing any signs of any abnormal post-contrast enhancement. We're seeing this structure here, which the signal was nulled on the fat suppression imaging. So this is fat. And then we have this hypointense structure here, which corresponds with the area of calcification. And not just calcification. If we look back, this is ossification. There is marrow within it. This represents an osteolipoma of the mesencephalon. This is not a tumor. This is not neoplastic. This typically is just going to be observed. So it's very important to characterize it fully. It's very important to use all the tools you have available, including use thin section imaging from the CAT scan, use fat suppressed post-contrast technique for the MRI. That way you can be very confident that there is not anything worrisome or suspicious about this. That allows the patient's family, and the neurosurgeons to know that this is not something that likely needs to proceed to surgery. Now, it may be appropriate to do a follow-up study at some point, especially if people are anxious or concerned, but overall, this is likely an incidental finding. This is an MRI of the brain in a 7-month-old child with macrocephaly or enlarged head. And we can see, if we go down, there's cystic enlargement of the posterior cranial fossa. And not only is there cystic enlargement of the posterior cranial fossa, that cystic area is in free continuity with the fourth ventricle, and the cerebellar hemispheres are splayed. We're not seeing an intervening cerebellar vermis. So if we look at this sagittal image, we can see the cerebellar vermis is hypoplastic, is uplifted. We see this is the superior medullary velum, but then normally that would reach the vestigium of the fourth ventricle, the little pointed portion of the fourth ventricle. We don't see that, and we do not see the inferior medullary velum. So this is a hypoplastic, uplifted cerebellar vermis in this configuration where the nose and the face is pointed this direction. You could, some people sometimes refer to this as counterclockwise rotation of the cerebellar vermis. Now, there's other abnormalities that we see as well. We can see this is the straight sinus leading to the torcula. That is elevated. The torcula is usually much lower in position. In particular, this right here is the nuchal ligament. The nuchal ligament attaches to the occipital bone, and there is a slight little protrusion known as the external occipital protuberance, where the torcula is at the confluence of the superior sagittal sinus and the straight sinus, laterally forming the transverse sinuses. There is an internal occipital protuberance. Now, if we look on this CAT scan, we can see the internal occipital protuberance, but that is markedly elevated from the location of the nuchal ligament, or where the external occipital protuberance would be. That right there is actually a finding that in the days of radiographs prior to CAT scans and MRIs, a lateral skull radiograph could be used to show this massive enlargement of the posterior cranial fossa because of elevation of the internal occipital protuberance. Well, this therefore is massive cystic dilation of the posterior cranial fossa in the setting of a hypoplastic cerebellar vermis and elevation of the internal occipital protuberance and its associated torcula. This is referred to as a classic Dandy-Walker malformation. In addition to a classic Dandy-Walker malformation, we see there's a developmental abnormality of the corpus callosum. There's AP foreshortening of the corpus callosum, and we see marked thinning of the posterior body, isthmus, and splenium of the corpus callosum. So this patient has, as their primary malformation, a Dandy-Walker's malformation, but they additionally have some posterior corpus callosal dysgenesis. This is a mid-sagittal transfontanal ultrasound in a one-day-old child that had an abnormal fetal ultrasound. And on this, we see some normal structures. We see the corpus callosum, see the midbrain, the pons, the brainstem. This is the cerebellar vermis, but inferiorly, we don't see the rest of the cerebellar vermis. We see something right here, but it's not connected to the remainder of the cerebellar vermis. One tool that we have more recently in evaluating the posterior cranial fossa on neonatal head ultrasounds is a transfontanal view. In this transfontanal view, this is somewhat of a sideways appearance. This is one cerebellar hemisphere, this is the other cerebellar hemisphere, and there's a separation between them. This is the fourth ventricle. So we start to have what looks like a hypoplastic cerebellar vermis. And one of the ways to better characterize that is on MRI. An MRI was performed at approximately 1 year of life. And if we were looking at the posterior fossa, we can see the fourth ventricle posteriorly connects to this CSF space here. And there's some separation of the cerebellar hemispheres. And there's a hypoplastic cerebellar vermis. If we look at the mid-sagittal T1 weighted image, we see the superior aspect of the cerebellar vermis looks normal, but inferiorly it's missing. This here is actually, we can see on this axial image, is portions of the cerebellar hemisphere protruding into the midline because there's no vermis to take its place and push it to the side. So there's some cystic prominence of the posterior cranial fossa in continuity with the fourth ventricle and hypoplastic cerebellar vermis. Now, this is considered to be in the Dandy-Walker spectrum of malformations. This is not a classic Dandy-Walker malformation where the posterior fossa is markedly dilated, where there is more severe hypoplasia of the cerebellar vermis and more uplifting of the cerebellar vermis. So this is a moderate severity Dandy-Walker spectrum malformation. In the past, people referred to these as Dandy-Walker variant, but the term Dandy-Walker variant to me is not appropriately descriptive. It doesn't tell you how severe something is. Dandy-Walker variant could, to some people, mean that 10% of the vermis is missing, or 50%, or 90%. Well, I think this one, approximately 50% of the cerebellar vermis is missing. So to me, this would be a moderate severity Dandy-Walker spectrum malformation. Now, additionally, we can see this is the location of the nuchal ligament insertion. Here is the torcula. So the torcula is slightly elevated from the insertion of the nuchal ligament. So there is some enlargement of the posterior cranial fossa, but it is nowhere near as severe as in the classic Dandy-Walker malformations. This is a head ultrasound on a newborn that had an abnormal fetal ultrasound with concern for an abnormal development of the posterior cranial fossa. And similar to the fetal ultrasound, it can be difficult to fully characterize the cerebellar vermis. Here's the fourth ventricle, and this is the cerebellar vermis, and it's hard to know where the cerebellar vermis stops. So this is definitely a time where MRI is more beneficial. In this case, we can see there is hypoplasia of the inferior aspect of the cerebellar vermis, but the vermis is present in nearly its entirety. We can see the superior medullary velum right here, inferior medullary velum. A normal cerebellar vermis looks sort of like the character for Pac-Man. It's about to trying to eat the brainstem. And in this case, most of Pac-Man is here, except Pac-Man has micronaphia. There's a hypoplastic inferior portion of the cerebellar vermis. So there's just a very mild inferior vermian hypoplasia and mild enlargement of the posterior cranial fossa, where this CSF space is in free continuity with the fourth ventricle. So we can look at this on a T2 weighted image, axial here, and you can see inferiorly, we're not seeing any cerebellar vermis between the cerebellar hemispheres. Superiorly, we see a normal vermis. So this is a case where there's near complete development of the cerebellar vermis, but while it's nearly completely there, it's not entirely there. In the past, people sometimes referred to this as a Dandy-Walker variant. The problem is that a Dandy-Walker variant doesn't tell you if this is a mild hypoplasia of the vermis or more moderate or more severe hypoplasia of the cerebellar vermis. This case, I would consider to be a very mild Dandy-Walker spectrum malformation. And I avoid the term Dandy-Walker variant because it is not a single entity. But if we qualify the description of this as being a mild Dandy-Walker spectrum malformation, I think it gives appropriate description to whoever's reading it that there are some features in the Dandy-Walker spectrum, but it is milder. I think that's important because there's a lot of confusion about terminology of the posterior cranial fossa malformations, in particular the Dandy-Walker spectrum malformations. And not every person is going to say the exact same thing. And not every book that you read is going to say the same thing. So if you're appropriately descriptive, saying a mild severity Dandy-Walker spectrum malformation, I think that's helpful. I think that's appropriately descriptive. And findings such as this very often can be clinically silent. This is a head CT on a 4-year-old boy with a headache. The head CT at first glance looks fairly normal. We're looking through it. We're not seeing any signs of hydrocephalus, any mass or anything like that. But as we go down lower, we can see at the level of the foramen magnum, there's fullness, there's soft tissue-like material posterior to the brainstem. With modern CT scans, we have the ability to have multiplanar reformats. And this sagittal reformat shows us cerebellar tonsils protrude caudal to the level of the foramen magnum. This can be approximated on CT, but the best characterization for this is on MR. MR, if we zoom in, allows us to see several landmarks. There is the basion, which is the inferior aspect of the clivus, in particular the basio-occiput portion of the clivus. And then we have the opistheon. The basion and opistheon represent the anterior and posterior margins of the foramen magnum. We can use that to draw a line between the basion and the opistheon to approximate the plane of the foramen magnum. And then we can make a measurement perpendicular to that line to see how far caudal to that plane the cerebellar tonsils extend. And here they extend approximately 9.5 millimeters below the plane of the foramen magnum. And that is typically considered to be a Chiari type 1 malformation. But how do we determine how significant this is? Well, the extent of tonsillar descent is one mechanism. But another tool we have is CSF flow studies. This is a dynamically acquired cardiac gated phase contrast image. This is acquired sagittally at the level of the foramen magnum. We can see the basic anatomic details that we see in the structural image. And as we scroll through the cine, we can see different phases of CSF pulsations. And we can see here the brainstem, the upper cervical cord. And so this is the cervicomedullary junction. And we can see that ventral to the brainstem and cervicomedullary junction, we have patent bidirectional flow of cerebrospinal fluid. We can see it going from dark to bright. So that is showing two different directions of flow. We're also seeing flow posterior to the brainstem at the level of the foramen magnum. So this is a sign that at the time the study is performed, there's not a significant alteration in CSF flow dynamics at the level of the foramen magnum. Now, one of the other things that's a part of a Chiari type 1 malformation imaging workup is imaging of the cervical spine. And we can see here the cerebellar tonsillar ectopia extending below the plane of the foramen magnum. And what we see of the cervical cord looks normal. We do not see any signs of a fluid collection within, either hydromyelia or syringohydromyelia. So this case is an example of a mild Chiari type 1 malformation without appreciable alteration in CSF flow dynamics and without evidence of syringohydromyelia. This is an MRI of the brain in a 3-year-old child that was referred in for a reported Dandy Walker spectrum malformation. Anytime someone comes in with a diagnosis like that, I always start from scratch in my evaluation. I don't take for granted that the entity was characterized accurately for two reasons. One is there's different terminology used in different places. Number two, a lot of the characterization performed when someone is very young can be difficult to fully understand the entire malformation. So it may be that at a young age, we thought it was a certain degree of severity or a certain type of malformation. But as the brain matured, grew, myelinated, that we can better understand what's going on. So I start from the beginning, and I can see there is cystic prominence of the posterior cranial fossa. There is continuity between that cystic prominence with the fourth ventricle. If I go to the sagittal image, we see there's a hypoplastic cerebellar vermis that is uplifted, and the fourth ventricle is in free continuity with this cystically enlarged posterior cranial fossa. I also can tell that the nuchal ligament inserts right here, and there's a little bump, which is likely the external occipital protuberance. And the torcula is actually right here, and that little bump right there is the internal occipital protuberance. So the torcula is markedly elevated relative to the position of the nuchal ligament. That is a sign of an enlarged posterior cranial fossa. And that was something that on a lateral skull radiograph could be used to raise question about a possible Dandy Walker malformation in the era of plain films. That's not the only finding that we see. Yes, this is a classic Dandy Walker spectrum malformation with a very hypoplastic, uplifted cerebellar vermis and markedly dilated posterior cranial fossa. But if you look closely, there is absence or agenesis of the corpus callosum. With that, we see absence of the cingulate gyrus. We see parasagittal gyri that extend to the third ventricle and radiate outward. We can see here that there's a parallel appearance of the body of the lateral ventricles. And on this coronal image, along the medial aspect of the parallel body of the lateral ventricles is this white matter bundle known as the Probst bundles, which are anterior posteriorly directed fiber bundles that are fibers that were intended to become commissural fibers traversing the midline through the corpus callosum. There's a vertically oriented third ventricle with direct continuity with the intrahemispheric fissure. There is a relatively low position of the distal branches of the anterior cerebral artery. These normally would be called the pericallosal artery, but I'm not sure if we can call it the pericallosal artery if there's no corpus callosum for it to wrap around. But there's a caudal position of the distal branches of the anterior cerebral artery. So this patient has a classic Dandy Walker malformation, but also agenesis of the corpus callosum. The constellation of findings definitely warrants further evaluation with genetic testing. In recent years, we've learned that one class of abnormalities that can result in this combination includes abnormalities of the tubulin gene or tubulinopathies. So this patient may benefit from a genetics consultation and evaluation for abnormalities such as a tubulinopathy. This is a 16-year-old child who was in a car accident, hit their head, and a head CT was performed to look for signs of intracranial traumatic injury. Fortunately, there was no signs of traumatic injury, no fractures, no bleed, or anything like that. But one thing that caught people's attention was this cystic appearing area here. Does not look like an acute traumatic etiology, but it definitely was puzzling, and it resulted in a brain MRI being performed. An MRI of the brain was performed and shows a normal development of the cerebellar vermis. We see the superior medullary vellum, the inferior medullary vellum. The little angle where they come together is called the fastigium. And there's a normal fastigial angle. Overall, the cerebellar vermis looks on this mid-sagittal image like the video game character Pac-Man, directed towards the brainstem. So the cerebellar vermis is normal. But there is prominence of CSF posterior to the cerebellar vermis. It's pushing slightly to the right, the falx cerebelli. This is demonstrating hyperintense signal on T2 weighted imaging. It suppresses on FLAIR imaging. It's hypointense on T1 weighted imaging. And it demonstrates facilitated diffusion. All of those other features help us know that this is just an arachnoid cyst. It's an arachnoid cyst behind the cerebellar vermis, so it's known as a retrovermian arachnoid cyst. This is normal. This is not a Dandy-Walker spectrum malformation. This does not require imaging follow-up. This does not require neurosurgical consultation. This does not require consternation on the part of the clinical team. This does not require anxiety on the part of the patient. This is a normal finding. Now notice, this retrovermian arachnoid cyst results in slight elevation of the torcula. So the position of the torcula alone actually is not a feature to diagnose or exclude a Dandy-Walker spectrum malformation. This patient does not have a Dandy-Walker spectrum malformation. This patient does not have any pathologic abnormality. They have a retrovermian arachnoid cyst, which is a normal variant. This is an MRI of the brain in a 2-year-old child being performed for seizure. Fortunately, the brain was normal and didn't show any abnormalities that would commonly be associated with causation of seizures. However, one area that was puzzling was the appearance of the posterior cranial fossa. At an outside institution, this was referred to as a Dandy-Walker malformation. Well, the first thing we do in evaluating this is look at the cerebellar vermis. We have a normal superior medullary vellum, normal fastigial angle, and a normal inferior medullary vellum. That is a normal fourth ventricle, a normal cerebellar vermis. If you have a normal cerebellar vermis, you do not have a Dandy-Walker spectrum malformation. So now we just have a little bit more likely CSF in the posterior cranial fossa. So let's evaluate it. If we look on the T2 weighted image, it's hyperintense. It's along the left aspect of the falx cerebelli here. The contents suppress on FLAIR imaging, so we know that it's not going to be proteinaceous fluid. We do not see any susceptibility abnormality within, so we know that it is likely not going to be hemorrhagic. We see facilitated diffusion. There's no diffusion restriction, so this does not represent an epidermoid cyst. So what does that leave us? We have an arachnoid cyst that's inferior to the cerebellar vermis, an infravermian arachnoid cyst. An infravermian cyst is a normal variant. Now, this is in a location and an appearance that people sometimes will refer to as a megacisterna magna. But the cisterna magna, the CSF space here, doesn't just get big on its own. it's usually distended because of a cyst. But this arachnoid cyst is a normal variant. In the absence of symptoms, in the absence of mass effect on other structures, an infravermian arachnoid cyst is a normal variant that does not require follow-up, does not require surgery, does not require any cause for consternation. So this is an infravermian arachnoid cyst, which is a normal variant. Otherwise, the brain is normal. This is an MRI of the brain in a 6-year-old child with seizures that at an outside institution was referred to as a Dandy Walker variant. Now, if we look, we see a normal development of the cerebellar vermis, and that normal development of the cerebellar vermis tells us that this is not a Dandy Walker spectrum malformation. There is no hypoplasia or intrinsic developmental abnormality within the cerebellar vermis. Now, there is prominence of CSF posterior and inferior to the cerebellar vermis. And if we look on this axial image, this CSF prominence, it's on both sides of the falx cerebelli, and it goes behind both cerebellar hemispheres. It's hyperintense on T2 weighted imaging, suppresses on FLAIR imaging, and demonstrates facilitated diffusion. So this is an arachnoid cyst. There is no significant mass effect upon the cerebellum. I think this more likely is, given the absence of contour abnormality, just chronic remodeling and chronic slight expansion of the posterior cranial fossa. We also see chronic elevation of the torcula and the superior angulation of the posterior aspect of the straight sinus related to this. So this is a retrovermian arachnoid cyst that's also infravermian, but there is no Dandy Walker spectrum malformation. So that's very important that there is not a malformation. Now, we do see CSF slightly prominent in the fovea of both cerebellar hemispheres. And in a child with chronic anti-epileptic medications, you sometimes can see that. But that's not an intrinsic developmental abnormality. So this patient does not have an intrinsic developmental abnormality. Therefore, there's no need to do a genetic workup for a cerebellar malformation. This is a retrovermian and infravermian arachnoid cyst. We just reviewed a number of cases of posterior fossa abnormalities. Some of them have similarities, some of them have differences. Hopefully, after reviewing these cases, you can better appreciate the similarities and the differences and the clinical implications of some. For Chiari-1 malformations, there are mild and moderate and severe malformations, and the measurement of the cerebellar tonsils below the plane of the foramen magnum is probably not the most important abnormality. Chiari-2 malformations have a variety of both posterior fossa and supratentorial abnormalities. The Dandy Walker spectrum malformations, they are varied to more pronounced posterior fossa malformations, possibly with genetic associations of the supratentorial findings, or a very mild abnormality. Then there's posterior fossa arachnoid cysts, which can be confused with the Dandy Walker spectrum malformation if you don't pay attention to the development of the cerebellar vermis. And then we also discussed several other entities, such as Joubert syndrome and rhomboencephalous synapsis, that round out a variety of posterior fossa malformations that at first may sound confusing, but hopefully make more sense now. This is an MRI of the brain in an 8-year-old female that was performed for headaches. And at first glance, all the major things that we look for are normal. The ventricles are normal in size. We're not seeing any mass. Now, notice you can see some movement artifact on this. This is very common in children, especially at around the 8-year age. Younger than that, we often sedate patients. Older than that, they can hold still. This small amount of motion artifact is actually, I think, an acceptable amount of artifact that allows this child to have an MRI scan without needing sedation. I think it's worth that. We won't miss anything if we look carefully at all the sequences. Now, as we go inferiorly towards the level of the foramen magnum, we're seeing the cerebellar tonsils at the level of the foramen magnum around the brainstem. We're seeing fullness here. That's then better characterized on this sagittal image. On this sagittal image, we can see the basion, which is the inferior aspect of the basi-occiput, representing the anterior margin of the foramen magnum. And we see the opistheon. This is also part of the occipital bone that represents the posterior margin of the foramen magnum. If we draw a line between the basion and the opistheon, we can measure the extent of cerebellar tonsillar ectopia. In this case, the cerebellar tonsils extend approximately 13 millimeters below the plane of the foramen magnum. But beyond that, we're also seeing a contour abnormality in the posterior aspect of the spinal cord. This is in conjunction with a paucity of CSF spaces. There is near complete effacement of the CSF space ventral to the cervicomedullary junction at the level of the foramen magnum. There's a slightly retroflexed odontoid process, and we're seeing effacement of the cisterna magna. So there's a paucity of CSF spaces here. So one of the things commonly that can be performed is a CSF flow study to look at CSF flow dynamics. An additional follow-up study can be imaging of the cervical spine. You may not have time to do them initially when you're first identifying this, but at follow-up you can. But beyond those findings, we need to look at all the images we have available, all the data we have available. And if we look in this sagittal image, we can actually see here syringohydromyelia in the mid-cervical cord. This is a CSF collection within the central canal of the spinal cord. So even though this is a dedicated brain study, we can actually see this abnormality here. So from my perspective, yes, we can at follow-up perform a CSF flow study, but they've already failed the physiologic CSF flow study. We already know there's an abnormal CSF flow dynamics at the level of the foramen magnum. Now, spine imaging becomes important to understand the caudal extent of this because we're not imaging this syringohydromyelia in its entirety. So this patient has a Chiari type 1 malformation with 13 millimeters of cerebellar tonsillar ectopia, but we already know they have syringohydromyelia. So this is a patient who likely would not benefit from conservative management and may require a posterior fossa decompression. This is a CT scan of the head in a 12-year-old female, and this is performed for headaches. In the process, we're seeing an upper normal caliber of the lateral and third ventricles. We're seeing the fourth ventricles normal in size. Otherwise, everything so far is looking normal. But it's always important to pay attention to the level of the foramen magnum. And we're seeing here, we're seeing the brainstem, and we're seeing the cerebellar tonsils. And a little bit of visualization of the cerebellar tonsils at this level can be okay, but we need to make sure that there's not something more going on. Fortunately, modern CAT scans have the ability for multiplanar reformats. And this image here, if we look closely, we actually can't really delineate where the cerebellar tonsils end. And it's very, very tight at the level of the foramen magnum. There's a paucity of cerebrospinal fluid. And if we look at the bone algorithm data, we can see there's somewhat of a retroflexed odontoid process. A retroflexed odontoid process is commonly associated with a Chiari type 1 malformation. An MRI of the brain was performed. And again, while there's a little bit of motion artifact, we can still get a very good idea of what may be going on. This is the basion, the inferior aspect of the basi-occiput, a part of the clivus representing the anterior margin of the foramen magnum. And this is the opistheon, another part of the occipital bone that represents the posterior margin of the foramen magnum. We draw a line between the basion and the opistheon. We can measure how far caudal there's cerebellar tonsillar ectopia. Now, that's a little tricky because everything is so tight. There's so little CSF, it's difficult to delineate what is brainstem and what is cervical cord and what is cerebellar tonsils. But the cerebellar tonsils extend at least 15 millimeters below the plane of the foramen magnum, potentially up to 22 millimeters. So in addition to that, we can see there's a paucity of cerebrospinal fluid. If we look closer at the rest of this image, we can see syringohydromyelia in the mid to lower cervical cord extending below the field of view into the thoracic cord. So we already know this patient has failed a physiologic CSF flow study. The next thing to be done is a posterior fossa decompression. If we look here, this is after decompression. We can see there has been resection of the inferior aspect of the occipital bone, opening up the posterior margin of the foramen magnum. So we now have a widely patent neoforamen magnum. They often will resect the inferiormost portion of the cerebellar tonsils, especially in a severe case like this, for two reasons. Number one, in a severe case like this, the cerebellar tonsils are at risk of obstructing even the neoforamen magnum after decompression. Additionally, the cerebellar tonsils, the tips of them, often are atretic and damaged from being pinched for so long. So this is a bony decompression. If the neurosurgeon feels like they need even more space, they can do a duroplasty to also open up the CSF space here to widen the dural space. This shows a successful bony decompression, but we can still see portions of the syringohydromyelia. But 6 months later, the syringohydromyelia has gone, has resolved. So the bony decompression without the duroplasty was successful in relieving the syringohydromyelia, and equally, if not more importantly, the patient's symptoms had resolved. This is a CT scan of the head in an 11-month-old child being performed for delayed milestones. So we can see the lateral ventricles and third ventricle, they're upper normal in caliber, but this can be normal at this age. The rest of the head CT is looking fairly normal. We can see the anterior fontanelle remains partially open, which is appropriate for this age. As we go posteriorly or inferiorly into the posterior fossa, we can see the cerebellar tonsils extending into the level of the foramen magnum and even caudal to the level of the foramen magnum. This is suggestive of a Chiari type 1 malformation. And an MRI scan is helpful to further characterize. Again, the landmarks that we look for are the basion and the opistheon to represent the level of the foramen magnum. If we draw a line between the basion and the opistheon, we can measure the extent of cerebellar tonsil ectopia. And the cerebellar tonsils, in this case, extend approximately 16 millimeters below the plane of the foramen magnum. But it's important to recognize that the most important features for evaluating a Chiari malformation include things like clinical symptoms and physiologic parameters such as CSF flow study and possibly the presence of syringohydromyelia, which is an indication of a clinically abnormal CSF flow study. Just the extent of cerebellar tonsillar ectopia alone is insufficient to fully characterize and understand a Chiari type 1 malformation. This patient on a CSF flow study actually has slight narrowing of the CSF space ventral to the brainstem at the level of the foramen magnum, but there's bidirectional flow of cerebrospinal fluid. Most importantly, upon a detailed neurologic exam by a neurosurgeon, this patient was asymptomatic. There was no syringohydromyelia. There was patent CSF flow dynamics at the level of the foramen magnum. And so this patient was just observed. And for 4 years, Upon repeat imaging, there was no further development of an abnormality. And over the course of 4 years, they decided to not pursue surgery. So this is an example that just the level of cerebellar tonsillar ectopia alone, in this case 16 millimeters, which sounds like a lot, is not uniquely sufficient to determine whether or not a patient needs to get a surgical decompression. This is a brain MRI in a 6-year-old being performed for evaluation of seizures. And the brain parenchyma looks okay. I'm not seeing any abnormality that we typically look for in a patient with seizures. However, I do see on this axial T2 weighted image, the cerebellar tonsils extend to the level of the foramen magnum. So we need to see, is that normal or abnormal? A sagittal view is the best one for that. And we find the basion, the inferior aspect of the clivus, in particular the basiocciput portion of the clivus, and the opistheon, a portion of the occipital bone representing the posterior margin of the foramen magnum. Drawing a line between the basion and opistheon, we can measure perpendicular to that the level of cerebellar tonsillar extent below the plane of the foramen magnum. And here, the cerebellar tonsils extend approximately 7 millimeters below the plane of the foramen magnum. Historically, greater than 5 millimeters below the plane of the foramen magnum has been considered to be a Chiari type 1 malformation. That was a somewhat arbitrary cutoff. In reality, a Chiari type 1 malformation, the clinical significance of it relates to abnormal CSF flow dynamics and symptomatology. We also know in children that 5 to 6, even 7 millimeters can be a physiologic finding. This patient, all the CSF spaces around the brainstem and the foramen magnum are patent. This patient had no symptoms attributable to a Chiari malformation. So this is very possibly a normal physiologic finding in this age group, that even up to 7 millimeters below the plane of the foramen magnum could be normal. Now, distinguishing between normal or borderline cerebellar tonsillar ectopia, which is what I would typically call this, versus a mild Chiari type 1 malformation, in some cases is an academic distinction, except if a patient is labeled with a definitive Chiari type 1 malformation, there's a risk that they may proceed to surgery at even minor symptoms that may or may not be attributable to the Chiari malformation. A majority of the population at some point will have a headache in their life. This patient, if they carry a diagnosis of a Chiari type 1 malformation, the first time that they have a headache, someone may wonder, is it related to the Chiari malformation? That's a reasonable thought. But we need to be careful on imaging to not just give measurements and give a diagnosis as a black or white answer. There are gray areas, and this is a gray area. So personally, I would consider this to be borderline cerebellar tonsillar ectopia. If you don't feel comfortable with that, you can say borderline cerebellar tonsillar ectopia versus a mild Chiari type 1 malformation. And what is the importance in distinguishing that? What are the other features that you need to know? Well, one, you need to know what are the clinical symptoms of the patient? And number two, you need to know your local neurosurgeons, what their philosophy is. And this is a topic I've had very detailed discussions with the neurosurgeons that I work with, and they agree. They do not want or need their clinic being filled up with patients that their cerebellar tonsils extend 6 millimeters below the plane of the foramen magnum, but are otherwise asymptomatic. And so it can be a tricky distinction, but we need to recognize that while historically people have been taught that the cerebellar tonsils extending 5 millimeters below the plane of the foramen magnum or more represents a Chiari 1 malformation, we need to recognize, number one, that a slightly greater caudal extent than that can be physiologic in children. And number two, that The key to determining management of a Chiari malformation is not a ruler. It is not the measurement. It is other features. It is CSF flow dynamics. It is the presence of syringohydromyelia. It is the presence of neurologic symptoms such as headache, tinnitus, other things like that. So this case is an important one to demonstrate that a Chiari type 1 malformation is more than just a measurement. This is an MRI of the brain in a 7-month-old child with seizures. And in the supratentorial brain, we can actually see some abnormalities in expansile areas of subcortical T2 prolongation and possibly some subpendymal nodules along the lateral margin of the body of the lateral ventricles, which are suggestive of tuberous sclerosis complex. But if we go to the posterior fossa, we can actually see what looks like fullness at the level of the foramen magnum. On the sagittal image, we can identify the basion and the opistheon. Drawing a line between them approximates the plane of the foramen magnum, and we can measure that there's approximately 9 millimeters of cerebellar tonsillar extent caudal to the level of the foramen magnum. This patient had tuberous sclerosis complex. They had no symptoms that we were aware of related to a Chiari 1 malformation. So they were followed closely because we knew that they were going to get detailed neurologic follow-up and detailed imaging follow-up. Well, a few years later, if we look, there's actually no longer any cerebellar tonsillar ectopia. And why is that? Well, one proposed mechanism of a Chiari type 1 malformation is that you have normal developmental growth of the cerebellum, but the posterior fossa is smaller than it should be. And because the posterior fossa or the container is too small, the cerebellar tonsils or the cerebellum just conforms to the container it has available, and the cerebellar tonsils start to grow caudally and extend caudally, where the volume of the cerebellum may be normal. It's just it has to contort to fit its container. But remember, this first started when this child was 7 months old. We know the brain grows after 7 months of age, but we know the skull grows. So this is an entity I've seen several times where you have a Chiari type 1 malformation at a young age that was asymptomatic and when followed ends up normalizing. This is an 11-year-old child with a history of myelomeningocele of the lumbosacral spine at birth that was repaired. So therefore, there's a known Chiari type 2 malformation. And we can see some of the posterior fossa abnormalities here that we'll go into in more detail. But while we're talking predominantly about posterior fossa malformations, we really need to also discuss the supratentorial abnormalities that go along with a Chiari type 2 malformation. We can see that there's posterior corpus callosal dysgenesis. The rostrum and genu are slightly thinned, but the body of the corpus callosum as we go posteriorly thins out, and we can barely see the isthmus and splenium of the corpus callosum. We have a large massa intermedia. The massa intermedia or interthalamic adhesion is typically large in Chiari type 2 malformations. If we look on this axial image, we can see this parieto-occipital predominant white matter volume loss. We also can see right here, there's a ventriculostomy catheter because here's a ventriculostomy catheter in the left lateral ventricle and another ventriculostomy catheter in the right lateral ventricle, because patients with a Chiari type 2 malformation very, very often will need a shunt for hydrocephalus. Now, there's some additional features we can see. If we go off to the side into a parasagittal image, we can see a lot of these sulci are fairly narrowly spaced and shallow. But this is not true polymicrogyria. Polymicrogyria represents a malformation of post-migrational organization. This represents an entity called stenogyria, Stenogyria, stenogyria. That's something that's commonly seen in a Chiari type 2 malformation. There's also an element of ulegyria, Ulegyria, which is gyri that are narrowly spaced, not due to a malformation of cortical development, but due to a paucity of white matter subjacent to these gyri. So we see the corpus callosal dysgenesis, posterior predominant white matter volume loss, a prominent massa intermedia. Well, what else do we see? There's somewhat of a horizontally configured appearance of the tectal plate, in particular, protrusion of the inferior colliculi. This is sometimes referred to as tectal beaking, which can be of variable severity. And then we see some of the more classic findings. We see the fourth ventricle is small and vertically oriented. It's very small. On this axial image, we can see the foramen magnum is very large. There's a large foramen magnum. And while in a Chiari type 1 malformation, we talk about cerebellar tonsillar ectopia, if you look closely, this is the cerebellar vermis. The cerebellar vermis extends below the foramen magnum too. So this is not cerebellar tonsillar ectopia. This is just cerebellar ectopia. So a Chiari type 2 malformation has cerebellar ectopia through an enlarged foramen magnum. We can see that the cerebellar tonsils are almost wrapped around the brainstem here. We can see the cerebellar vermis extending this low. So this is a patient with a Chiari type 2 malformation with many of the very characteristic findings. This is an MRI of a 13-month-old child with a known lumbosacral myomeningocele. And we know that a lumbosacral myomeningocele has essentially a 100% association with an intracranial Chiari type 2 malformation. So this MRI, the sagittal T1 weighted image, shows we see a vertically oriented, very small in caliber fourth ventricle. We see an abnormal appearance of the cerebellar vermis and cerebellar ectopia, which includes the cerebellar tonsils and the cerebellar vermis. We will confirm that on the axial images. You can see cerebellar tonsils and the cerebellar vermis extending down into an enlarged foramen magnum. We're seeing several other features. We're seeing a large massa intermedia. We're seeing somewhat of a beaked appearance or posteriorly pointing appearance of the tectal plate related to a more horizontal appearance and configuration of the inferior colliculi. Now, every patient with Chiari type 2 malformation is a little bit different. This patient, the corpus callosum, doesn't look too abnormal. We're seeing somewhat truncation of the rostrum of the corpus callosum, but the genu and the body of the corpus callosum are normal. We have the physiologic thinning of the isthmus, and we have the splenium of the corpus callosum. The corpus callosum may be slightly smaller than usual, but this is not as abnormal as we sometimes see. Here we see what may be an interhypothalamic adhesion. This is a finding that has been seen slightly more commonly in the setting of a Chiari type 2 malformation. Notice other adjacent structures. There's the massa intermedia. There's the anterior commissure, the optic chiasm. But this structure right here, just posterior to the lamina terminalis, might be an interhypothalamic adhesion. If we look on this Chiari type 2 malformation, we can see there's a ventriculostomy catheter in place because there's a near 100% association of Chiari type 2 malformation with hydrocephalus. Now, with the ventriculostomy catheter in place, the ventricles are now normal in size, so it's doing its job. But we see another interesting finding that's characteristic of Chiari type 2 malformations. We see interdigitation of gyri across the interhemispheric fissure. This is felt to be related to fenestration of the falx cerebri. And in this case, you actually could even see this finding on this coronal head ultrasound at 1 month of life. So we're seeing interdigitation of gyri, in the setting of a Chiari type 2 malformation with the characteristic posterior fossa